welcome to the FlightBridgeED Podcast series. Hey everybody, Eric with you with FlightBridgeED. Today we're going to talk about something that's pretty interesting. I did a podcast about 3 months ago on permissive hypotension and the use of a MAP pressure to guide resuscitation. When we were taught back, 10, 15 years ago, a lot of people guided resuscitation off of blood pressure, and I think there's multiple research articles and papers out there that have shown that that's kind of misguided. And so now we kind of resuscitate based on a MAP pressure. And if you remember from that podcast, or if you haven't heard that podcast, you can go into our bank of podcasts and you can listen to it. It's, again, the permissive hypotension. And I briefly talked about DIC in that podcast and the importance of maybe reducing our fluid resuscitation and reducing our volume as it relates to normal saline and LR, and maybe giving more packed red cells, FFP, and platelets, etc. Today I wanted to talk about what's kind of become a big deal in the HEMS industry and medicine is the Lethal Trauma Triad. And I know throughout the 22 years I've been in EMS, things have changed immensely. We have completely done a 180 as far as how we treat our trauma patients. And so I thought it would be fitting that we do a podcast on that. Before we jump into that, I came across a website that kind of triggered this and made me think a little about this. And that website is called the Hurt Registry. And the Hurt Registry was founded just recently, and it was founded by a few gentlemen that wanted to try to educate the HEMS industry, medical directors, EMS, etc., in the proper management of our trauma patients as it relates to acute traumatic coagulopathy. So essentially, DIC. Are we performing care that's actually increasing morbidity and mortality because we're doing it improperly? And so all the research has shown that we need to, again, decrease the amount of fluid we're giving. We want to maintain a MAP pressure of 60 to 65. We know that gives us good tissue oxygenation. It perfuses our brain. It allows us to have a good MAP pressure. And you got to remember the whole analogy that we talked about in that initial podcast. If I had a bottle of water and that bottle of water was half full and I stabbed it, and so we're simulating a penetrating trauma, and I squeezed that, and that's a simulation of basically increasing the blood pressure. What's going to happen to that fluid in that bottle? The fluid is going to come pouring out. And so we have to remember we need to manage our patients kind of similar to how we would manage a AAA. We want to keep that blood pressure as low as possible, keep that heart rate down, and not stress the heart and not increase SVR. If we increase SVR, we're going to actually squeeze and we're going to cause the hemorrhage to increase. So we need to realize that. There's a few things we need to talk about when it comes to this lethal trauma triad. The first thing we need to realize is that hemorrhage is the biggest cause of death when we're talking about traumatic injury, and it accounts for 30 to 40% of trauma mortality and 50% in the first 24 hours of the presentation secondary to the injury. So that's a big deal. Just like we treat every patient when we talk about sepsis, we talk about any insult, anaphylaxis, we want to try to get control of the actual source. And that's no different in the traumatic injury patient, right? We need to get control of that hemorrhage. We need to stop that bleeding. But the lethal trauma triad, it encompasses some things that I think as clinicians we can actually really look at, we can change, and we can actually decrease morbidity and mortality by just being cognizant of the things that we're doing. So what is that lethal trauma triad? Well, the first thing it's hypothermia. The second thing is acidosis, and then the third thing is that coagulopathy, so that DIC secondary to those things. So let's talk about that. The first thing that we have to remember is in any shock state, we have to define shock. And shock is basically defined as inadequate tissue perfusion. And so if we looked at that in simple terms, essentially your oxygen demand is exceeding the delivery. Okay, so essentially what we're saying is we're going from an aerobic state where we're actually producing enough ATP to drive cellular function. Remember, we have 36 ATP produced in an aerobic state, and then we're progressing to an anaerobic state where we produce more acid. If you remember from my podcast on oxygenation, we produce more acid more quickly in an anaerobic state because that Krebs cycle and electron transport chain, that whole process is basically stopped, and we just form glycolysis, and that glycolysis and that splitting of that sugar to pyruvate produces acetyl-CoA and CO2 very, very quickly, very efficiently. So that's where we have that increased acid. The shock situation is essentially a poor amount of oxygen being delivered to the tissues. If hemorrhage is the main source of morbidity and mortality, and hemorrhage basically dilutes us down where we don't have oxygen carrying capacity, you're basically causing hypemic hypoxia. And hypemic hypoxia is going to be directly related to that shock situation where your demand is higher than what we're getting delivered. Okay, so that essentially is shock, and shock drives everything, and we know that. So let's look at this lethal triad and kind of break down each thing. So we talked about hypothermia, we said acidosis, and we said coagulopathy. So let's talk about those things. Hypothermia. I don't think we do a very good job as clinicians. I can tell you that I've flown for the last 10 years, and I'm guilty of it just like anybody else, where in the summertime we take the burrito wrap, the nice comfortable big blanket that we can wrap the gurney in, we take that and we stick it in the aft compartment, and we think, well, it's 110 degrees outside, our patients are not going to be cold. And that's absolutely false. They've done many studies, military studies, and you need to understand that all the research, all the information that we get from trauma comes from conflicts, military conflicts. And what they've seen in Iraq and Afghanistan is that these patients in these field hospitals where it's 120, 130, 135 degrees are still delivered hypothermic. Okay, so we have to remember that. So how does that happen? Why does that happen? Well, we know based on everything we've learned in EMS or in nursing, we start with ABCs, and we start with airway and breathing, and we go down the circulation, right? And we go down to disability, and we look at the neuro aspect. And then we go to E, and E is exposed. And we've all been taught to have our trauma shears out, and we cut the clothes off. And we've been taught this so we can actually identify secondary injuries or any life threats that we may miss otherwise. But what are we doing? This is kind of a double-edged sword. As pre-hospital providers, now we basically are using these scissors, and we're using as samurai swords, and we're killing our patients because we're not very good at maintaining warmth once we cut their clothes off. You know, we cut their clothes off, they're laying on a cold backboard, and that cold backboard just sucks the heat right out of them. You know, we take them to that level 1 trauma center, and what do? The first thing, they put them on the table, they strip them off, they take the blankets off, and they're assessing them, and they're out to the elements. So that ambient environment, their body is going to just suck the heat right out of them. And so before long, they're hypothermic. Their temperature drops very, very quickly. How does hypothermia relate to this clotting cascade? Well, we know that the clotting cascade is essential for slowing that bleeding down, whether it's a penetrating trauma or a blunt force trauma, whether it's, you know, your spleen is bleeding out from a lateral impact or whatever. So we have excessive bleeding, we've got hemorrhage, and we have to have that clotting cascade working efficiently to try to slow that bleeding down. Well, what happens when we strip all the clothes off of our patients and we're assessing them and we don't do a good job maintaining that warmth is the patient's clotting cascade actually decreases, and it doesn't work effectively or efficiently. The body quickly loses the ability to clot, and it correlates directly to the temperature of the patient. So the lower the temperature goes, the more that clotting cascade actually decreases and decreases to where we lose that effective means to clot. All right, so hypothermia is a huge, huge aspect. And I would argue that that's probably one of the easiest things that we could do as clinicians to reduce morbidity and mortality is to keep our patients warm. So how can we do that? Well, I think we can be a little bit more aggressive with keeping our patients warm, even in the summertime. Keep those thick burrito blankets on the stretcher at all times, whether it's summer or winter. Keep it on there. Strip them down and immediately cover them for warmth. And I think we've been taught to do that in our pediatric and our neonate patients, but we forget to do that in our adult patients. So for me, looking at this lethal triad, that is something that we can correct very, very easily. So remember, hypothermia directly affects that clotting cascade. The lower the patient's temperature, the less efficient our clotting cascade is providing clots and building that fibrogen mesh and slowing the bleeding down. All right, so we can correct that. So we also said in a shock state by definition, again, is inadequate tissue perfusion. Well, I said that in a hemorrhage patient, you're losing oxygen carrying capacity. We don't have the hemoglobin concentration to deliver oxygen to the tissues effectively. So in turn, we're going from an aerobic state to an anaerobic state. That in turn causes an excessive amount of acid production. And we know that an excessive amount of COPD production is going to drive our pH down, and we're going to go into a metabolic acidosis. Well, that is the second part of this lethal trauma triad, is acidosis. So how do we fix this? Well, first thing is we got to get control of the source, right? We got to stop the bleeding. And the only way we can do that in our situation or in our setting is to get them to a trauma center as quickly as possible. If you have a limb or an arm or a leg that's actually severed, we need to put a tourniquet on and stop that bleeding. So whatever we can do to try to stop that bleeding is going to effectively slow the acidosis process. A surgeon is the only one that's going to be able to fix that problem. But what can we do? Well, we can optimize oxygenation. This is where I've argued for years, where if you have a patient that may be maintaining their airway fine, they're breathing, they're talking to you, their GCS is 13, but they're hemorrhaging out, you know they've got mechanism, it may be a better option to RSI that patient, put them on the ventilator, optimize oxygenation the best you can, add PEEP. If you remember my podcast just recently, apply Henry's Law, right? Henry's Law states that we increase concentration. So we increase from 21% to 100%. We then increase surface area by adding PEEP, and we do positive pressure ventilation by adding the ventilator. So I believe the ventilator could be a great tool in this whole lethal trauma triad. Even though you've got a reduction in hemoglobin concentration, if you optimize oxygenation by RSIing your patient, it may buy you some time, and you're going to lower the incidence of acidosis. All right? And then the third thing is the coagulopathy. Well, we talked about that. Hypothermia directly affects coagulopathy, but so does volume resuscitation. If we're giving our patients so much volume that we're actually liquefying their blood and we're turning their blood into Kool-Aid, we're actually causing clotting cascade to not work effectively as well. And so, like I said in my earlier podcast on permissive hypotension, maintain a MAP pressure, remember not a blood pressure, a MAP pressure, at least 60 millimeters of mercury, and that's going to effectively give you good tissue oxygenation to your brain. It's going to perfuse your kidneys, and you're going to keep that blood pressure low enough to where you're going to slow that hemorrhage down. Remember, if we increase SVR, we're going to cause us to bleed out more. That effectively is going to reduce oxygen carrying capacity, and you're going to have a higher incidence of acidosis. So it's very, very important to give just enough fluid, just enough volume to maintain a MAP pressure. All right? And so I would argue that don't look at a blood pressure. I think we can get really tunnel vision on blood pressures. I think we can look at a blood pressure of, let's say, 89/60 and look at that and go, man, our patient is hypotensive. But again, look at the MAP pressure. Remember, if your monitor doesn't have the capability of measuring that, which I believe most do nowadays, your MAP pressure is diastolic times 2 plus your systolic divided by 3. And so you can do that very, very easily, just jotting those down. So again, your diastolic times 2 plus your systolic divided by 3 is going to give you a MAP pressure. Now, let's say you have a head injury patient. That MAP pressure has to be a little higher. And if you have a head injury patient, which a lot of our trauma patients do, we need to maintain a MAP pressure about 80 to 90 millimeters of mercury. And we know that your MAP pressure is essential in maintaining a cerebral perfusion pressure of at least 70. So your cerebral perfusion pressure is your MAP minus your ICP. And your ICP is just kind of a arbitrary number you have to just guess. And a normal MAP pressure is anywhere from 0 to 15. So I always take the high number, 15. I minus that from my MAP of 90, and that gives me a cerebral perfusion pressure of 70 to 75. And so that's where you want to keep that. And so again, that kind of makes it a little bit more difficult when you have a patient that's has a neurological insult or head injury like that. So you're going to have to keep that MAP a little higher. So let's recap here. when we talk about this lethal trauma triad, we got hypothermia, we have acidosis, and we have coagulopathy. I want to hit a little bit more on the hypothermia aspect. And I think this is probably the biggest area that we can actually make a difference. And so think about also what happens to your patients that are hypothermic. What do they start doing? They start shivering. And when we start shivering, we start generating, or I should say we start using up a lot of energy. Well, what is our energy source cellularly? It's ATP. And we talked about earlier that ATP is generated through both aerobic metabolism and anaerobic metabolism. With aerobic metabolism being a very efficient way, we produce 36 ATP. Anaerobic metabolism, we only generate 2 ATP. So if you have a patient that's shivering and they're utilizing all this energy to shiver, they're burning all this ATP. They're also hemorrhaging out. They're bleeding inside. And by bleeding inside, they're actually reducing their oxygen carrying capacity. And by doing so, oxygen being delivered to your tissues is actually decreased, right? So that goes back to our demand far exceeds what's being delivered. And if we have a shock situation where we're not getting good tissue oxygenation, what happens? We go from an aerobic metabolism state where we're generating an abundance of ATP, 36 ATP for every glucose molecule that's converted, to an anaerobic state where we're only producing 2 ATP. So now we have kind of a double-edged sword. We're hypothermic, we're burning through ATP in an abundance, but we're also in a hypemic hypoxic state. We're in a shock state. We're actually going from an aerobic state to an anaerobic state where we're not producing enough ATP. So you can see very quickly that hypothermia is going to cause a multitude of problems. It's going to cause you to become very acidotic very quickly. It's going to cause that clotting cascade to be decreased. It's not going to be very efficient. And so you can see hypothermia, out of all the things that we listed in this lethal trauma triad, is probably the biggest thing that causes a multitude of problems, that causes that cascade to really compound and kill your patients. And so I would argue that that's the biggest thing that we can correct. And then, like I said, the patient comfort aspect. We all like to be warm. We all know what it's like to be sick or injured, and being warm is a big thing. So remember, with your fluid and your volume resuscitation, if you haven't heard the podcast on permissive hypotension, keep that volume to a limited amount. If that means you only have to give 500 cc's for a trauma patient to maintain a MAP pressure, then that's all you got to give. They need to be volume resuscitated the proper way with packed red cells, with FFP, and things like that to maintain that clotting cascade and in the proper amounts. So remember the patient comfort aspect. The patient comfort aspect is a big deal, and we all know what it's like to be sick or injured, and we want to stay warm. So be very aggressive with maintaining good patient temperatures, keeping them warm, keeping the aircraft a little warm, making your comfort secondary and the patient comfort primary. And then the last thing I want to say is, if you haven't listened to the podcast on permissive hypotension, just remember we have been so aggressive in the past by giving volume and 2, 3, 4, 5 liters of fluid to maintain a blood pressure. And remember, stay away from blood pressures. Do pulse checks, maintain a MAP pressure of 60 to 65, like I said, maintain a cerebral perfusion pressure of 70, and so you may have to have that MAP pressure a little bit higher for your neurological insult patients, or head injury patients, I should say. And, just keep all these things in the back of your mind and really be aggressive with this hypothermia aspect and keep your patients warm. So that's all I'm going to go over on this podcast. If you haven't listened to other podcasts relating to this, there's a great podcast I did on cellular respiration. It kind of goes really in depth regarding aerobic and anaerobic metabolism. I did a podcast on oxygenation, ventilation. We touched on Henry's law and gas laws, and as it relates to optimizing oxygenation. And we did a podcast on permissive hypotension and the importance of reducing the incidence of DIC. And so I thought it would be, again, fitting to do a podcast on this lethal trauma triad. Check out the HURT registry. Check out that network. If you're working for a hospital or you're working for a flight company that is actually doing TXA, or you're doing FFP in the field, or whatever, go onto this website. You can actually kind of do a bio and put your protocol in there. And this is a great way to get the word out. So medical directors, so hospitals, so these level 1 facilities can see what we're doing, and we can kind of spread the word and get this out there. So again, on behalf of everybody at FlightBridgeED, we want to thank you. We want to thank you for following us on Twitter. We want to thank you for following us on Facebook. If you haven't checked out we've got some new things. We've got a published book on our website and on Amazon.com. It's a fully encompassing 200-page critical care book that goes through every critical care system as it relates to advanced certification review. It's got test questions throughout. It's got rationale. It's a great book, so check that out. So thanks again for following us, and we'll talk to you soon.
We want to thank you for following FlightBridgeED.